Heather, you can start.
Okay, great. So thank you guys for attending. Um, my name's Heather Leitch and I'm a hematologist at St. Paul's Hospital. I did have the pleasure of starting out in a lab at UBC actually. And so, I know that the CBR focuses on benign hematology, but I did want to talk to you, and I usually talk to you guys about iron overload and MDS, which is really my area of focus for the last few years. But I just wanted to talk to you also about sort of the development of targeted therapies for hematologic malignancies, which has just been, I think, it's something very exciting over the last couple of decades. So this is our scheme of hematopoiesis, which I'm sure you're familiar with. So over here you have the hematopoietic stem cell, and over here you have the differentiated cells. So on the left side, we have very undifferentiated, but a high capacity for proliferation. And on the right side, very limited capacity for proliferation, but highly differentiated. So I actually started out in chronic myelogenous leukemia in the lab on campus. And this is a disorder that shows up in the mature granulocytes, which usually we're referring to neutrophils when we say that, but also eosinophils and basophils can be involved in the CML clone, as well as neutrophil precursors. It's actually a stem cell disorder, but where it manifests is in these differentiated cells. And so it's a myeloproliferative neoplasm that is characterized by dysregulated production and proliferation of mature and maturing granulocytes with fairly normal differentiation. For some reason, my animation is not coming up. Okay, let's just see. Try that again. So it's associated with the fusion of two genes, the BCR and the ABL, resulting in a BCR-ABL fusion gene. So you have the N-terminal sequences of BCR with the C-terminal sequences of ABL. And it results from a reciprocal translocation between chromosomes 9 and 22, and the exact translocation is shown there. It gives rise to an abnormal chromosome 22 called the Philadelphia chromosome because it was discovered, guess where, in Philadelphia. So the fusion gene results in formation of a fusion transcript and then a fusion protein that includes the tyrosine kinase domain from ABL, but it's unregulated because it's missing its N-terminal regulatory sequences. So that's what's implicated in CML pathogenesis. And clinical hallmark is production of granulocytes and their precursors, which I said. And in the absence of treatment, CML progresses from a chronic phase to an accelerated phase and then a terminal blast crisis. And the median survival of CML patients without definitive treatment is only 3 years. So this is showing the Philadelphia chromosome discovered in 1960 by Noel and Hungerford. And this is actually the first human malignancy that a recurring chromosomal translocation has been found. So that's one of the things that's exciting about CML. So this is normal chromosome 9 and 22, and this is the translocation resulting in the fusion gene. So this is a normal blood smear. Forgive me if I'm telling you things you already know, but you can see that the neutrophils are multi-lobed and they're nicely, granulated, and they're a little bit bigger than the red blood cells, which look fairly normal. I think you can appreciate that there's way too many white blood cells here, mostly neutrophils, and also some precursor cells. And then this higher magnification shows an eosinophil and also 1, 2, 3 basophils. And so, I can go for a couple of years looking at people's smears and not see a basophil. So this is very unusual. So in 1995, the only potentially life-extending treatment for CML was an allogeneic stem cell transplant or bone marrow transplant. However, only 1 in 9 patients were young and fit enough for this procedure and had an appropriate donor. So of patients undergoing stem cell transplantation, the transplant-related mortality is 1/3, and that's the chances of dying of the transplant toxicity within the first 100 days or 3 months. 1/3 were cured with potential complications such as graft versus host disease, which can be devastating, and 1/3 relapsed. So there was obviously a need for better treatments. And this is where I started grad school. I actually came to grad school. It was kind of where people were producing monoclonal antibodies, and I thought that sounded very, very cool. And I ended up in this immunology lab using immunological techniques to study CML. So one of the mysteries of human cancer is that though the abnormal cells are more frail, they do come to predominate. And so in the lab, antibodies were produced against normal bone marrow cells and affinity columns created. CML cells were lysed and the lysate passed over the normal affinity column. And what came through was termed CAML for common antigen in myelogenous acute leukemia. It actually isn't acute leukemia, it's chronic leukemia, but I didn't name it. And so then using hematopoietic progenitor and stem cell assays, I embarked on defining the activity of CAML on normal and malignant hematopoietic stem and progenitor cells. So this is a long-term culture. You put buffy coat cells into a flask with the appropriate nutrients, and they form an adherent layer of macrophages and nurse cells that support hematopoiesis. There's some of the hematopoietic cells, and this is a colony forming assay. And so, if you're looking at these under a dissecting microscope and you take a tiny little micropipette with a tiny little bulb on it, you can pluck these colonies and put them on a glass slide and flatten them and stain them and identify what kind of cells are in them and know what progenitor they came from. So to cut a long story short, this is showing inhibitors of serine proteases on normal and CML colony formation. So this is normal cells. So you get these many colonies with the cells only. If you add CAML, it almost halves the number of colonies. If you use this specific sequence, so it doesn't actually affect the colonies one way or another. And if you add CAML, again, they're similar to the normal non-CAML treated cells. So CAML is suppressing normal colony formation, but at the same time, it was actually increasing CML colony formation. This activity was also blocked with this short peptide bound to this protease inhibitor. And in fact, we use different peptides, or I use different peptides, and showed that the blocking activity was specific to this peptide. So I got very excited about this and, thought, well, what if instead of clobbering a patient with an allogeneic bone marrow transplant, which most of them aren't even eligible for because they're too old, what if we could just, inject this protease inhibitor, once a day or once a week or whatever, and, control the cells that way. Well, it wasn't too much longer before along came imatinib. And so this is the active BCR-ABL resulting in CML. And imatinib actually was specifically formulated to block the tyrosine kinase domain of the fusion protein. And so it blocks CML activity. And so this is another first. So it was the first chromosome translocation. It was the first fusion gene to be found to be associated with the human cancer. And this is the first specific targeted therapy for a human cancer. So lots of exciting things in CML. So in 1998, Dr. Brian Drucker from Oregon and his colleagues tested imatinib in a phase 1 clinical trial, and imatinib caused the CML cells to disappear in the majority of patients in chronic phase. And 5 years later, 98% of the patients from this trial were still in remission. And so, as I said, imatinib is the first targeted therapy. We now have second, third, and fourth generation BCR-ABL inhibitors for clinical use. So it's really revolutionized the treatment of CML. And this was from May 2001. It was on the cover of magazines as a Time magazine. They called it the Magic Cancer Bullet. At the time, I was doing a lymphoma fellowship at BC Cancer, and I would have patients with lymphoma walk into clinic and ask me for the Magic Cancer Bullet. And I had to, tell them it wasn't going to help them, unfortunately, but we're coming to lymphoma. So I thought I'd intersperse just with some short case descriptions so you can appreciate the impact that this has had on people's lives. So I saw a 30-year-old man in 2010 for an asymptomatic increase in neutrophils and precursors on regular blood work. He was otherwise well. Physical exam was unremarkable. Bone marrow showed CML in chronic phase. He started imatinib, achieved cytogenetic and molecular milestones, remained undetectable long term. He and his wife had a baby with no adverse effects on the baby. He did have side effects, mild rash and GI side effects. And based on more recent data showing that for patients who have an undetectable transcript for at least 2 years on stopping the tyrosine kinase inhibitor, 50% remain in molecular remission long term, and 50% recur, and then you just restart the medication and they're fine again. So he stopped imatinib in 2022 and he remains undetectable in 2024 with resolution of his rash and GI symptoms. So how is that compared to being clobbered with an allogeneic stem cell transplant and possibly dying from the transplant or the complications or recurrent CML? So, it's interesting because at the time that I was doing the work with Camel and saying, wow, what if this could be a targeted therapy? People in the department were like, well, that's science fiction. But here we are just a few years later, and we have this fantastic treatment. So CML is pretty boring anymore because it's just easy to treat. So I just wanted to turn to lymphoma for a few minutes. So this is an abnormal clonal growth of the lymphocytes of the immune system. There's two major groupings, Hodgkin's and non-Hodgkin's lymphoma. Non-Hodgkin's are quite diverse. They're mostly derived from B cells. Some are T cells, and we rarely get NK cell lymphomas. Clinical manifestations, prognosis and management of lymphomas vary widely according to the type of lymphoma. So this is a previous WHO classification of non-Hodgkin lymphoma. You can appreciate how many subtypes there are here. A common subtype is an aggressive B cell lymphoma called diffuse large B cell lymphoma. So this is where this occurs in hematopoiesis, is in a B cell precursor cell. So this is a normal lymph node, and so it's kind of a bean shape, and it has these follicles of cells and interfollicular areas. This is obviously a higher magnification, but this is diffuse large B-cell lymphoma, and pathologists aren't very imaginative, so they kind of it's a descriptive term. So the cells are large compared to normal cells here, and they're diffusely spread throughout the lymph node biopsy. Hence the name. This is Hodgkin's lymphoma. So this is the malignant cell. It's called a Reed-Sternberg cell after the doctors that discovered it. And it's on a background of polyclonal inflammatory cells. Coming back to diffuse large B cell, the first improvement in survival was seen in the early 1980s with introduction of the anthracyclines, one of the classes of chemotherapeutic agent. So the CHOP regimen was standard. So the anthracycline is the H for hydroxydonorubicin or doxorubicin. In the 1990s, every group had a newer, better CHOP. And finally, a randomized controlled trial was done comparing the regimens, which showed that they completely overlapped with each other in terms of survival. So my favorite is Promace-Cytobom. I really like that name for some reason. So everyone went back to CHOP because it was simpler. Then we had the appearance of monoclonal antibodies as a treatment in the clinic. So rituximab is a monoclonal antibody against CD20, which is a B cell marker expressed on diffuse large B cell lymphoma and many other types of B cell malignancy. And just to remind you, there's two heavy chains, there's two light chains, and they compose an antigen binding site, which is very specific. So this is the first trial done in elderly patients with diffuse large B-cell lymphoma, showing that adding rituximab to CHOP gave significantly better event-free survival than CHOP alone. So now this is very standard therapy in diffuse large B-cell and many other types of lymphoma as well. So that came into the clinic in 2004 in British Columbia. There are newer targeted therapies in DLBCL. It's recognized to be more complex in the era of genomic profiling than the morphology suggests. Polatuzumab is a monoclonal antibody against CD79B, which is expressed on B cells, and vedotin, which it's conjugated to as a cellular toxin. And Pola with CHIP, taking out the O, but adding rituximab shows promise in certain subtypes of DLBCL and is approved for use in BC. Brentuximab is another antibody that binds to CD30 on the Hodgkin's-Reed-Sternberg cells and is effective in patients with advanced stage disease. And obinutuzumab, which is another anti-CD20, is also effective in B-cell malignancies such as chronic lymphocytic leukemia. There are other antibodies, for example, nivolumab, that activate an immune response against lymphoma cells. So this is nivolumab, this is the trade name. And so without, the T cell binds to the cancer cell through these receptors, and with, this receptor is blocked, and so it allows the T cell to be active and attack the cancer cell. There's also Bruton tyrosine kinase inhibitors in CD5 positive cells. So here's the CD5, and I'm not going to go into details, but stuff happens with the CD5 signaling, and Bruton tyrosine kinase inhibitors are effective. So they are taken orally once to twice daily with very few side effects. And they're very effective in CLL, mantle cell lymphoma, which is an aggressive non-Hodgkin lymphoma, and Waldenstrom's macroglobulinemia, also called lymphoplasmacytic lymphoma, which is an indolent B-cell non-Hodgkin lymphoma. We also have now bispecific T-cell engager or BiTE antibodies. So the above monoclonals have one specificity on both arms of the antibody, which I showed you. Epcoritamab and glofitamab are bispecific antibodies for B-cell non-Hodgkin lymphoma. So one arm binds an antigen on the B cell and the other to cells of the immune system and puts them next to each other. So it allows an immune response against the lymphoma cells. So here's your BiTE antibody. This binds the lymphoma cell, and this has a different specificity and binds to immune effector cells. And these are just brand new. We're just starting to use them in clinic in the last few months in British Columbia. We also have CAR T cell therapy, or chimeric antigen receptor T cells. And I'm not going to go into details, but basically you take cells from the patients, train their T cells to attack their specific lymphoma and reinfuse them into the patient. And this is approved now in British Columbia as third-line therapy for aggressive non-Hodgkin's lymphoma. So turning to a patient, this is all very fine and good, but what impact does this have on clinical care? So there's a 62-year-old man who was in the emergency department one week when I was on service with severe pain to the groin and diaphragm, progressive, worse at night. His baseline is that he runs marathons several times per year. So this is a very fit guy. His CT scan showed lymphadenopathy, and a core left iliac lymph node biopsy was done. On examination, he was very well and fit, very slight swelling of the right leg, otherwise normal. When you do a biopsy, the first thing that comes out is the flow cytometry. It showed CD5 positivity, and he actually is a colleague. So of course he's looking up his own results and emailing me saying, "Oh my God, I've got mantle cell because mantle cell is CD5 positive." And I'm saying, let's just wait for the pathology, and thinking, oh my God, he's got mantle cell. So his Ki67, which is the proliferation index, is 80%. So that's consistent with an aggressive lymphoma. He had a PET scan done. This is positron emission tomography. So CT scans show structure, whereas PET scans show metabolic activity by glucose uptake. And it was widely positive to a SUV max of 16.5, which is consistent with aggressive disease, with multiple bony lesions, which is not a good finding. Yeah, that's just what I said. So his pathology actually showed diffuse large B-cell morphology with overexpression of MYC and BCL2, and FISH, fluorescence in situ hybridization, was negative for translocations activating these two oncogenes. And so this is what we refer to as a double overexpressor, or DEP DLBCL. So when I meet anybody with a hematologic malignancy, I say to them, this is a condition where the cells grow more than they should and don't die off the way that they should. And this is kind of a prototype because MYC is something, I'm sorry for the sirens in the background. I hope you can hear me. 90% of them are heading east along Hastings. So MYC is something that drives cells through the cell cycle. So it's causing them to grow more than they should. And BCL2 opposes programmed cell death. So it's causing them to not die off the way that they should. So CD5 positive DLBCL comprises about 5 to 10%, so it's a minority. Common features are advanced stage and inferior response to therapy. More intensive regimens have not shown superior outcomes in the double overexpressors. However, there was a small study presented at the American Society of Hematology meeting in 2022, showing in 46 patients with DEP DLBCL, zanubrutinib, one of the Bruton tyrosine kinase inhibitors, plus CHOP-R or ZR-CHOP, resulted in impressive remission rates and 1-year overall survival in the ballpark of garden variety DLBCLs treated with standard therapy. So this is their abstract. The response rate after 6 cycles of ZR-CHOP, and we normally give 6 cycles of therapy in advanced stage aggressive lymphoma, was higher than that of the previous report after R-CHOP for the double overexpressors. So it was 86 versus 70%. And progression-free survival at 6 months was 97%. And at 12 months, 85%. And these are very impressive numbers. I'm going to show you some curves in a minute. At diagnosis, his albumin was 27, a normal is 40. So this is just showing how catabolic he is. He started zanubrutinib, which I got for him on compassionate access on cycle 1 of 6, day approximately 15. His albumin actually improved to 36 from 27 prior to cycle 2. So this is, the cycles are at a 3-week interval. This is within a couple of weeks. His albumin just really impressively improved. Now, at the same time, this publication came out, CD5 gene signature identifies DLBCL sensitive to BTKIs. So that is actually one of our researchers at BC Cancer. So this is standard therapy. And the ones with the CD5 positive signature, look how poorly they do. This is their progression-free survival, so much inferior to CD5 negative. But in this particular study with R-CHOP plus ibrutinib, the first generation BTKI, here's the overall survival. This is 5 years. It's 100%. So it's a dramatic improvement in outcome. And so post cycle 4, he had a PET scan that was negative. So he's in a PET negative complete remission. His energy was low until I talked to him just earlier this week. He now feels like he's back to normal. He's running almost his full distances. He's working full time. It's just really very remarkable considering what difficult lymphoma he started out with. So this is obviously very gratifying. Turning next to multiple myeloma. So this occurs here in the plasma cells. I've added this plasma cell. So it's a neoplastic proliferation of plasma cells that produce a monoclonal immunoglobulin. They proliferate in the bone marrow and can result in extensive skeletal destruction with osteolytic lesions, osteopenia, and pathological fractures. The diagnosis of myeloma is often suspected because of one or more CRAB features, so hypercalcemia, renal failure, anemia, or bony lesions. And there's no curative therapy. In 2004, when I started in clinical practice, the treatment options for patients over 70, which is the majority because most patients with any hematologic malignancy, the median age of onset is 65 to 70, was melphalan and prednisone. And once they had progressed on this after 1 to 2 years, the only option was palliation. For patients under 70, induction with cyclophosphamide followed by an autologous stem cell transplant gave a 5-year progression-free survival. But if you're under 70, just gaining 5 years is not very good. Then we had the introduction of the proteasome inhibitors, such as bortezomib, also called Velcade, for the treatment of relapse refractory myeloma. It's a proteasome inhibitor, which I'll show you a picture. It's well tolerated, extends progression-free survival. So this is the proteasome, which a colleague of mine describes as the garbage disposal of the cell. So if you have, a protein that's targeted for destruction, it's ubiquitinated and this directed to the proteasome where it's degraded. We now also have lenalidomide, which is an immunomodulatory agent that was introduced in 2006 as a third option for myeloma. This is the immunomodulatory effects. It's obviously complicated, which means that nobody understands exactly what it does, and I'm not going to go through this. Newer options include carfilzomib, which is a second-generation proteasome inhibitor, pomalidomide, an immunomodulatory agent, ixazomib, another proteasome inhibitor, daratumumab, which is a monoclonal antibody against CD38, which really improves the outcomes of these patients, and teclistamab, which is a bispecific antibody, and coming soon we'll have CAR T-cell therapy for myeloma. So with first line now, daratumumab, lenalidomide, dexamethasone, the progression-free survival is 5 years, equivalent to that of autologous stem cell transplant. And with all these second and third line therapies available, although it's non-curable, you can, often keep patients going for multiple years with this malignancy. So I'm going to tell you about a patient. He had an interesting complication of myeloma. 75 years old, seen in the hospital in 2019, had been admitted with a pelvic fracture. Skeletal survey showed multiple lytic lesions throughout the skeleton with advanced osteopenia, and his urine protein electrophoresis showed a small paraprotein with free kappa light chains. Serum protein electrophoresis was negative. Bone marrow biopsy showed 40% plasma cells, so this was diagnostic of myeloma. So it's oligosecretory. So a small proportion of patients don't present with a paraprotein. They present with myeloma that secretes very little paraprotein. And so they often present with advanced disease, in this case, advanced skeletal disease, because, it's not picked up until late. So he was given a course of cyclophosphamide, bortezomib, the proteasome inhibitor, and dexamethasone with good response on bone marrow biopsy. And I followed him with bone marrow biopsies every 6 months because his SPEP, UPEP, and serum free light chains were just unreliable because he's oligosecretory. So this is a normal bone marrow biopsy. So you have bony tuberculi and you have the hematopoietic cells, and you can see some pink and some purple. So there's a balance between different cell types, and these empty areas are fat cells. This is myeloma, obviously a different magnification, but all you see is plasma cells, plasma cells, plasma cells with their, eccentric nuclei. They're called clock face nuclei because if you use your imagination, they look like a clock. They have this clear area adjacent to the nucleus, which is endoplasmic reticulum, pumping out monoclonal antibodies, and you can have some abnormal forms such as binucleate and even trinucleate cells. This is amyloid, and so this is cross sections of blood vessels, and in the subendothelium, this is staining with something called Congo red stain, and it causes what we call apple green birefringence with polarized light. So this is something that you may hear in the future. So what happens is because of the specific physical chemical characteristics of the paraprotein, they form into what's called beta pleated sheets, and then protofibrils and amyloid fibrils. And these basically deposit into tissues and organs and cause all sorts of mayhem. And once they get in, it's kind of like concrete. You have a hard time getting them out. So in the heart, it can cause congestive heart failure. In the liver, hepatic insufficiency, hepatomegaly, hepatic failure. In the spleen, it can actually act like a sponge to absorb factor IX and factor X and cause deficiencies and bleeding. In the blood vessels, this is the most common site of bleeding. Because it's subendothelial, it keeps the small vessels from contracting, so you get bleeding because they can't react to bleeding. So it happens rarely in myeloma, and with classical treatments, the median survival was about 6 months. More common with lambda than kappa, just because of their characteristics. With the introduction of bortezomib, lenalidomide, and monoclonal antibodies, reports of reversal of organ deposits emerged, although it's difficult to document who gets reversal of organ deposits, as special scans are needed. And as far as I'm aware, there's only one of these scanners in the UK. They were for a few years developing a special antibody that busted up the amyloid fibrils, but it's kind of disappeared, so there must have been problems with it. In any case, this patient, so first of all, it's incredible that he developed amyloid when he has very little paraprotein in the first place, and very difficult to diagnose because you often do a bone marrow biopsy, and although he'd had several, we may not have captured blood vessels on those biopsies. So he started daratumumab CyBorD. He's just completing the CyBorD portion, and the daratumumab maintenance will continue, and I'll continue to follow him with bone marrow biopsies and hope that this has bought him some time. So this is this is actually quite a character. He's 80 now, and he has this group of friends that refer to themselves as the Romeos, retired old men eating out. So turning now to chronic, I think this is CLL. It's under my little menu there. So this is in the B cell. Yes, it is CLL. Chronic lymphocytic leukemia, or small lymphocytic lymphoma, when it happens in the lymph nodes predominantly, is a mature B-cell neoplasm characterized by progressive accumulation of monoclonal B lymphocytes. You'll hear more about this from Rayanne. This is the most prevalent leukemia in adults in Western countries, accounting for up to 35% of all leukemias in North America. The median age of onset, like everything, is 65 to 70 years. In less than 10%, CLL presents primarily in the lymph nodes. So this is a CLL blood smear. Again, you can tell there are way too many white blood cells, but they're small and they're mature, and normal lymphocytes are supposed to be about the same size as a normal red blood cell. So they're about right. And here you have actually what we call smudge cells. So these are kind of busted up cells. Malignant cells are actually more fragile than normal cells, so one of the mysteries of cancer. So this is CLL infiltrating a lymph node, and you can see it doesn't have those follicles that I showed you before in interfollicular areas. This is just sort of taking over the whole lymph node. Most patients have early stage CLL, which requires monitoring but not treatment. When problems develop, such as lymphadenopathy that's causing symptoms or signs, systemic symptoms, unexplained fevers, drenching sweats, unexplained weight loss, or immune cytopenias, treatment is needed. And in 2004, the treatment for CLL was limited to chlorambucil and prednisone in older or unfit adults. In younger patients, fludarabine was used. Towards 2010, rituximab was added to these regimens with some benefit, and the first Bruton tyrosine kinase inhibitor, ibrutinib, was FDA approved in 2013. So the second generation is acalabrutinib, the third generation is zanubrutinib, and we're now having a fourth generation BTKI under development. So this is one of my patients, 58 years old in 2007. HIV positive since 1999, well controlled on highly active antiretroviral therapy. Physical exam showed no lymph nodes, no hepatosplenomegaly. The CBC showed normal white cell count, hemoglobin, platelets are a little bit low. Lymphocytes were 5.3, the upper limit of normal is 3.5. Flow cytometry for cell markers showed a capoclonal CD20, 19 positive, 5 positive, 23 positive, diagnostic of CLL. We took a watch and wait approach. In 2012, he was diagnosed with rectal cancer, received radiation therapy. It was complicated by terrible skin reactions and bacterial and viral skin infections requiring prolonged hospitalizations. In November 2012, I saw him in the emergency room when his platelets dropped to 18. Bone marrow biopsy showed megakaryocytic thrombocytopenia. In other words, the bone marrow is producing megakaryocytes, so they're being consumed peripherally. So this is consistent with immune thrombocytopenic purpura secondary to the CLL. He started on regular IVIG infusions, intravenous immunoglobulins, for the ITP secondary to CLL and also for infection prophylaxis. By 2013, in June, he developed multiple lymphadenopathy to 4 centimeters. His spleen is enlarged. Platelets are 62. His neutrophils are 0.8, which is low. And then he's diagnosed with an epidural abscess. And in January 2014, he dropped his hemoglobin to 90. Spherocytes were present on the smear. His direct antiglobulin test was positive. He started on chlorambucil, and rituximab was added once the lymphs are less than 30, so it doesn't cause a cytokine release syndrome. Why didn't I use fludarabine in this guy? Fludarabine is T cell toxic, and he has HIV, so I wasn't feeling good about that. So he was treated to October of 2014 with minimal response. His counts are still low. And this is just showing spherocytes. So instead of a normal red blood cell where you have that area of pallor because it's a disc, you've got these round cells, so you lose that area of pallor. So by November, his nodes had recurred. He became transfusion dependent, requiring 2 to 3 units of red cells every 2 to 3 weeks, multiple platelet transfusions. In January 2015, bone marrow biopsy showed a packed marrow, and ibrutinib had just become available on a compassionate access. And so he started on ibrutinib and tolerated it very well. His nodes completely melted away within 2 to 3 weeks. He was amazed. Everyone was amazed. His cytopenias did persist, but they started to improve in February of 2015. Hemoglobin normalized. Platelets went from, sort of 20-ish to 40-ish. Neutrophils eventually went to 0.4, which was okay. Not perfect, but okay. He did die earlier this year, 17 years from diagnosis at age 74 of unrelated causes. So I would have lost this guy back, I think, in 2015 rather than 2024. I think the ibrutinib gave him another decade. So turning to myelodysplastic syndrome, as I said, this is my area of focus, particularly iron overload. So this is where MDS occurs in the grand scheme of hematopoiesis. The usual clinically significant cytopenia in MDS is anemia. Dysplasia means that the blood cells look abnormal under the microscope, and the bone marrow cells look abnormal. And because they're being formed abnormally, they're broken down in the bone marrow, don't get into the peripheral blood, and this causes cytopenias. So here's your normal transferrin saturation in green. As you transfuse, the transferrin becomes completely saturated. You get the presence of non-transferrin bound iron, which can deposit into the tissues and organs, including the liver and the heart, as well as the bone marrow. But because of its redox chemistry, can react and form reactive oxygen species, or ROS, or oxygen-free radicals. And these have been shown in multiple studies to damage lipids, proteins, and nucleic acids. So you can imagine this could have consequences for cells. So in terms of targeted therapies in MDS, these are limited. In MDS with what's called del5q, which is the deletion of the long arm of chromosome 5, which is less than 5% of patients, lenalidomide is effective, and that's the same lenalidomide that we use in myeloma. In lower risk MDS with an SF3B1 mutation, which is a mutation in the spliceosome, luspatercept is effective. In higher risk MDS, hypomethylating agents such as azacitidine and decitabine prolong progression-free and overall survival. And some lower risk MDS patients may respond to erythropoiesis stimulating agents, or ESA, such as erythropoietin. But the median response duration is only 1 to 2 years, and on loss of response, there are few treatment options other than chronic transfusions. So transfusions necessary for survival, but negatively impact on overall survival and very much on quality of life, and results in iron overload, which is toxic to tissues and organs. This is a schema of erythropoiesis from early on the left to late on the right. And what you have is responses to luspatercept in these progenitor cells. So this shows randomization between luspatercept in blue and placebo. This is the percentage of patients obtaining a response. So we require transfusions, but the body has no mechanism for getting rid of excess iron from transfusions. So hematologists who treat patients with hereditary anemia, such as thalassemias, have a lot of experience with the benefits of iron chelation therapy to organ function and overall survival. But in Western countries, there's kind of a disconnect between centers and hematologists that treat malignant hematology and those that treat benign. So I think there's has been an educational gap. And also because MDS patients are older than thal patients and thought not to have sufficient life expectancy to benefit from offloading iron. Iron chelators are not, and also because iron chelators are not particularly easy to use, I think there's been a slow uptake of iron chelation in MDS. But at St. Paul's, we see the entire spectrum of hematology. So we see the benign, we see the malignant, we see everything in between. And we did an analysis in 2006. This is my first student project with two students, Tricia and Karen Wong and Tricia Goodman. And we showed that in low risk MDS, the patients who received iron chelation had better survival than those that did not. And this became very big news and became an area of active investigation for me, and really has resulted in I think better education for malignant hematologists, better outcomes for the patients. And so we have, as a group of Canadian hematologists, the Canadian Consortium on MDS, or CCMDS, here we are down here. We actually made an online algorithm for the management of MDS. This is a similar algorithm that we put together for the management of iron overload in MDS. You can access it. It's called the Iron Road because that's literally the name for railroad in Italian, ferrovia. This is a train engine. You can access it in English or French. And it gives you an overall algorithm, lower risk MDS information on what that means, higher risk MDS information. Are they eligible for allogeneic stem cell transplant? Information on what that means. Are they transfusion dependent? Do they have a reasonable life expectancy? Do they have documented iron overload? If no, monitor and information on how to do that. If yes, reduce iron overload, preferably by inducing transfusion independence with MDS treatments. Information on iron overload and transfusion in the usual clinical setting and in the stem cell transplant setting. If you can induce transfusion independence with luspatercept or ESA, it takes you to information on phlebotomy. If not, it takes you to information on chelation. We've got levels of evidence, grades of recommendations, future directions, and references. So all the information is there on this one website instead of having to look at 500 different papers to figure it out. It also, like the ClearPath, it has a step-by-step algorithm, which takes you to a treatment recommendation for your patient. In the MDS ClearPath, we call it the treatment wizard. Here we call it the IR Express. So this is just one excerpt from those step-by-step questions. Are they eligible for therapies that induce transfusion dependence? If yes, it takes you outside the MDS ClearPath to talk about what those therapies are. If no, it takes you to information on chelation. If they received a therapy that can induce transfusion independence, it takes you to information on phlebotomy. So we do participate in a national study of quality of life in MDS patients, and we collect data on our MDS patients. And we did, one of the criticisms of the previous data I showed you is it's retrospective. So there could be selection and referral biases. One of the advantages of the Canadian registry is it's prospectively collected data. And so we looked at all our patients, and sure enough, those who received chelation had better survival than those that did not. But then we controlled it further with a series of matched pair analyses, matching patients for characteristics thought to portend better or worse survival. And all of our matched pair analyses also showed improvement in survival in our patients receiving chelation. We do know that label plasma iron, which is a redox active subset of non-transferrin bound iron, appears at a transferrin saturation over 80%. So we actually went back to the Canadian MDS registry and did an analysis of 700 patients and found that sure enough, those that had a transferrin saturation over 80% had inferior overall survival to those who had a lower transferrin saturation, but also also had worse cardiac death-free survival as well. And so, you know, last year I showed you all sorts of reasons about how it could be molecularly affecting, you know, structures and organelles and stuff in the cardiomyocyte and affecting signal transduction. I'm not going to get into that here, but this is work that Cecilia Kim did. She was a CBR summer student in 2020. Colleen Wong looked at iron overload and cardiac toxicity in MDS. She's now a family practice resident. She also looked at iron overload in AML. Shannon Wong, yes, her older sister, looked at iron overload and infections in MDS in 2017, and also looked for screening for paroxysmal nocturnal hemoglobinuria in MDS in 2016. Brad Williamson looked at autoimmune manifestations of MDS and also MDS in one of our HIV patients. Harp Kochar wrote up a case of durable transfusion independence in MDS with iron chelation. Erica Sang looked at reduction in ferritin levels with response to ESAs in MDS and also in response to azacitidine in higher risk MDS. And I grayed out Trisha and Karen because that was before the CBR summer studentship program, at least for people doing clinical research. But all these other students and all this work has been supported by the CBR summer studentship projects. So I'm very grateful for that. And of course, at the CBR, we have the very clever Jay, who is working on making organ-targeted chelators that are also less toxic than the chelators we currently have access to. And this is my most recent project. I've just really finished writing up a review of how iron overload interacts with specific somatic mutations in MDS, which is kind of the wave of the future. So specific recurring somatic mutations have been recognized in MDS and have led to a molecular prognostic score, which is more specific than previous prognostic scores. And so I've been reviewing the literature and elucidating, how does, SF3B1 mutation affect iron physiology and affect oxidative stress and vice versa. And this is ready for submission. I'm going to submit it on the weekend. Finally, we were invited to write a how I treat iron overload in MDS for blood, which is a very big deal. And so this is from our visual abstract. So who, how, why, and when. And this is the other part of the visual abstract. I don't have it in one slide yet. So this is accepted for publication just, I think, a week ago. And so that should be coming through to blood, soon to blood. Very quickly, I know I'm a minute over. I do want to leave time for questions, but I wanted to talk about AML, acute myeloid leukemia. So this is where the defect in myelopoiesis occurs. It's very aggressive. For younger patients, intensive chemotherapy is given with or without allogeneic stem cell transplant. For older patients, it's too intensive. The median survival without treatment is only 3 months, so pretty brutal. With azacitidine, this can be extended. However, azacitidine, the hypomethylating agent, can take up to 6 months to produce a response. So if you've got something that's you're going to live with for 3 months, but you have to get to 6 months to get a response, obviously it's a very small set of patients who are going to have a benefit. BCL2 is overexpressed in many hematologic malignancies, including AML. As I said, it opposes programmed cell death. Venetoclax is a BCL2 inhibitor that's now used in combination with azacitidine, and the median time to remission is 2 months, so that's much better. These are AML blasts, so unlike the CLL that I showed you, they're huge. Look how big they are compared to the red blood cells. They also have very dispersed nucleoplasm, very active, and they have nucleoli. So these are bad if you see them under the microscope. So this is my final case, 74-year-old man diagnosed in July 2023 with lower risk MDS. He had these mutations, ASXL1, ZRSR2, and DNMT3A. His IPSS score was low risk. The IPSS revised was very low risk. And the IPSS-M was also low risk. This is the molecular score, giving a median I misspelled that. Median leukemia-free survival of 6 years, overall survival of 6 years, 1.7 chance of developing AML at 1 year. Well, guess what? At 1 year, he had circulating blasts noted on the peripheral blood, admitted to hospital to expedite workup, and bone marrow biopsy showed 60% blasts. And so the diagnosis was AML. He started Van-Aza and he's tolerating it well. He's just into cycle 3. And so hopefully will maintain a remission for a long period of time. Basically, patients get 1 to 2 year benefit from Van-Aza if they respond. He also was found to have a FLT3 mutation. So sorry, they get about 1 year, 15 months compared to 10 months with AZA alone, compared to 3 months with no treatment. So his bone marrow biopsy did show a FLT3 mutation, which is sensitive to a targeted therapy called gilteritinib, which can be used at progression. And then you can get another 9 months. And now there's a second targeted therapy come onto the market for FLT3 mutation, which I think is, I can't remember the name of it off the top of my head. So I guess my main point is how cool a career is that. I came to grad school, and started working on this thing that turned out to have translational potential and was excited about targeted therapies. And now I've watched this huge growth in targeted therapies over the last, years that I've been training and practicing. So they've increasingly become mainstream. It's very intellectually rewarding for those of us who think at a cellular or molecular level, very gratifying to see patients benefit with increased survival and decreased toxicity. And thank you so much for paying attention to all this. And I'm happy to take any questions now, or you can email me later if you think of something later. So thanks very much.
Thank you.
Hopefully I didn't shock you into submission with all that data.
Well, Heather, you did. Thanks so much for that whirlwind tour of your world. I have a lot of questions because, I'm not a physician. I don't understand anything in what you do. But, you talk about targeted therapeutics, and for DLBCL, multiple myeloma, and CLL, you talked about maybe 20, maybe more targeted therapeutics. In each one of those 3 pathologies, you talk about subsets, each targeting a different aspect of mechanism. So what kind of evidence do you go on which of those therapeutics you would treat a patient with?
Yeah.
Each one of those therapeutics has got to be worth at least 10 grand minimum a year for each one of those people, going up to about maybe close to 100 grand a year for CAR T. So how do you choose?
Yeah. So thank you for asking that question. So we choose based on clinical trials. So we look at the evidence. What is it that provides improved progression-free and overall survival? And, we're very fortunate to have a very proactive BC Cancer Agency, which, uses evidence-based data to access therapies for our patients. And you're quite right, CAR T-cell therapy is very expensive, but it is life-extending. But because of the complexity of some of these therapies, and CAR T-cells, I think, are a very good example, it actually really took a very long time for this to come into clinical practice and be available for our patients, which of course is very frustrating if you've got someone who needs it right now. It now is available to sort of a small number of patients as they kind of work out the technical kinks. We had a really interesting hematology semi-annual update just a couple of weeks ago, where one of the things they talked about was there's a local lab in Victoria who are working on sort of ramping up the manufacture of the CAR T cells so that hopefully it will bring the cost down of the CAR T cells exponentially. And hopefully that in future will make this available to more patients. In terms of, how are we going to do all these therapies? I think with therapies such as the Lendex in myeloma, which gives the same progression-free survival as an autologous stem cell transplant. Autologous stem cell transplants for myeloma are half of the transplants done by leukemia BMT over at VGH per year. And so I think that as we move into non-transplant first-line therapies for myeloma, that frees up their time to do cellular therapies like CAR T cell therapy.
I have one more related question. Can you use multiple therapies to improve efficacy?
So taking
So
myeloma.
these would be targeting different aspects of
Yes.
comparable pathways.
Right. So in combination, I think is what you mean. Yeah.
Yeah.
So I think people are starting to look at that. I guess, one of the examples is the ZR chop that I used in this guy. So we've got an antibody plus gluten tyrosine kinase inhibitor. That kind of comes also with clinical trials. So there are clinical trials of time-limited therapies in CLL, for example. So if you put someone on ibrutinib, which I do for a lot of my patients, because a lot of my patients are 80 years old, and they're a good 80, but they're still 80, right? So they can't take a lot of toxicity, but they have to stay on it till progression. So that can be many years, as I showed you in my otherwise unfit patients. The alternative is there are time-limited therapies such as ibrutinib or venetoclax in combination with obinutuzumab, one of the CD20 antibodies, and that's given for a year and then they stop and they're done until it recurs and it's the next therapy. But the trade-off is that you have to be kind of young enough and have the organ reserve to tolerate more intensive therapy. So yes, people are looking at combining targeted therapies. I guess another, example is the polatuzumab in combination with, CHOP or CHIP-R, that sort of thing. Yeah. But we're not quite there yet with, a lot of combinations of just targeted therapies and, eliminating chemotherapy, which I think is really the goal in a lot of these hematologic malignancies. And I have to say that patients really like the idea of not chemotherapy, which I would too if I were in their shoes. So in CML and CLL, we've gotten there, but for the more aggressive leukemias and lymphomas and so on, we're not quite there yet. We are with the older patients with AML because those are both targeted therapies, the hypomethylating agent and the venetoclax, but we're not there for the younger patients. It hasn't replaced chemotherapy and stem cell transplants. So that's kind of a long answer to a short question. Hopefully that was provided some good information. Yeah.
Other questions? Have we got some questions from the ether? With that, Heather, thank you so much for taking the time to join us today.
It's a pleasure. I'll see you at Research Day. Bye.
Bye.